Well, today we're honored to have Dr. Supiano here from the University of Utah to give us a talk on his research efforts. He is a professor of geriatrics at the University of Utah and is the Grech director at the Salt Lake City VA. He started his undergraduate education and medical school training at the University of Wisconsin before moving on to the University of Michigan for his postgraduate training and joined the faculty there. In 2005, he was lucky enough to move to the University of Utah, and for those of you who have hiked the wonderful canyon country of Utah, you know how wonderful that place would be to go. His official title today, better get this right, Arterial Stiffness, Frailty, and Outcomes from the Systolic Blood Pressure Intervention Trial. So without further ado, it's up to you.
Thank you so much. So can everyone hear this? Is that too loud? It sounds loud to me, but okay. And we're remote. I wanted to make sure I told people I'd wave to them that they're out there in the bar shop somewhere in the cyberspace. So is it possible to get the lights down in front? Because as was pointed out, you don't have to actually go to southern Utah to hike or do these things. So this is a picture of the campus in Salt Lake City. And this is not a view that you see very often. This is actually taken from our main campus, and I was on the 14th floor of one of the buildings on main campus. So this is looking straight east. These are the Wasatch Mountains. And the medical center is here. So the School of Medicine building is right here. This is the Division of Geriatrics. University Hospital, the VA, and our Grech program are just off to the right here a little bit. And I was telling people earlier about my where I live. So this is Immigration Canyon, and my home is just 7 miles up on the other side of that ridge. So you don't have to walk. You don't have to go to southern Utah and go to the national parks. I can walk out my back door, and that's where you are. So we are recruiting faculty to come to Utah. So Nick didn't know that when he extended the invitation to come. But so please see me afterwards, and we'll chat about life in Salt Lake City. So I'm really grateful for the honor to be here and speak to the Barshop Institute. It's a special honor to connect with Dr. Masro, and Ed, it's great to see you. Thanks so much for coming. I am going to speak a bit about this work, and I'm actually going to go in reverse order. So I realized when I had the outline here that it's reverse order from the title, but we'll cover these three major topics. So the disclosures I have first are R01 that was funded, thankfully, from NHLBI as an ancillary study to the SPRINT project, which I'll be talking about, but I have no other financial relationships to disclose. So the outline, what I'll cover, as I said, kind of going in reverse order, I will review the clinical aspects of the SPRINT trial and focus on the SPRINT senior component, which I've had the most direct interaction with, and this, as I'll describe, was a group of individuals above the age of 75, and talk specifically about outcomes in this population as a function of frailty status. So that's the SPRINT outcome results in frailty. That'll take about the first half of the hour, and then I'll shift gears and discuss some of the physiological characteristics of aging that pertain to the development of hypertension with age, and try to point out that vascular stiffness is a cardiovascular risk factor, and set the stage for the ancillary study that I have, looking at arterial stiffness as an outcome in the SPRINT trial. So with that, the outline for the SPRINT senior component, I'll focus in on the design and the geriatric outcome measures that thankfully were incorporated into the design of SPRINT at the outset, and in particular our ability to look at frailty status and gait speed as outcomes in this clinical trial. Point out the baseline characteristics of this cohort, describe the results by both frailty status and gait speed, and importantly address the concerns that arose and that may still be out there related to the adverse events that were reported, as especially focusing on injurious falls. So by way of background, the SPRINT trial, the systolic blood pressure intervention trial, was designed to address this question. Will lower blood pressure reduce the risk of heart and kidney disease, stroke, or age-related declines in memory and thinking? So that was the general research question that was posed at the time the SPRINT trial was initiated. It planned to and did enroll over 9,000 participants at over 90 clinic sites, and I learned that the VA here in San Antonio was one of the clinic sites, so some of you may be directly familiar with SPRINT participants. And at the end of the day, the trial was designed to inform us about whether a lower recommended blood pressure, namely a systolic target of below 120, would help to decrease stroke, heart disease, progression of chronic kidney disease, and age-related losses of memory and thinking relative to standard therapy, which would be a systolic target of less than 140. So that was the overall design. The trial design is shown here. So again, the randomized clinical trial to examine these effects to a more intensive blood pressure target than what was currently recommended. So individuals were randomized to either standard treatment with a goal systolic of less than 140 or an intensive treatment arm to achieve a goal of less than 120. And the clinical trial design was published in 2014. So the main outcomes from SPRINT were reported late in 2015 in the New England Journal of Medicine, and I'll just show this one slide that shows the major news that led to the early stop of the trial. So this is one point to emphasize. The trial was designed to go 5 years, but because the DSMB identified a separation between the two arms with respect to the primary outcome and total mortality, the recommendation to NHLBI was that the active intervention in SPRINT should be terminated. So this was in September of 2015 at 3.26 years into the trial. So keep that in mind. I'll come back at several points. So the reason that it stopped early was that the intensive treatment arm demonstrated a significant benefit. So for the primary outcome, which was a composite of myocardial infarction, acute coronary syndrome, stroke, heart failure, and cardiovascular death, the intensive treatment group here in the orange had a significant reduction in the rate of these events compared to standard treatment, so a 25% reduction overall over the 3.26 years in the primary outcome. In addition, and frankly unexpectedly, well, to be honest, all of these results were unexpected, and certainly at this early point in the trial, but the impact on all-cause mortality was not anticipated, and a 27% reduction in hazard ratio, again, over 3.26 years over the period of that time. Yes, sir?
Well, I'm sorry to bother you, but for the myocardial infarction, the stroke, and the coronary artery disease or whatever, this intensive treatment and also the standard treatment, those the effect is independent from the cholesterol level?
So, yes, so I don't know if the people chiming in can hear the question. Should I repeat the question?
Yes, if you can, please.
So the question is, were these effects independent of cholesterol? So there was, I think on the demographic slides, I can show you the proportion of folks who are on statin. There was no active attention paid to lipid control. The majority of people were on statins, as is true in this population, this high-risk cardiovascular population. And I don't recall if in the statistical analyses that lipids were taken into account, but there really was no difference between the two arms in terms of cholesterol management. Does that address the question? Okay. And by the way, I'd be happy to entertain questions along the way, as long as we finish. We go till what time, just so I can...
Yeah, we actually have an hour and a half.
Oh, okay, fine.
And they'll press that button, which means they should be able to hear.
Okay, great. Yes, please.
So maybe you're going to go on to talk about this, but both men and women were entered into this trial?
Yes.
And you're going to elaborate what you mean by intensive treatment?
Yes.
And that goes beyond pharmacological?
It is mainly pharmacological, and the short answer is to get to this goal of 120 took one additional antihypertensive medication on average. Does that, and the gender I'll point out in just a second. So this was why the study ended early, and this publication was concurrent with the American Heart Association meeting in November of 2015. So I got involved with the Sprint Senior, the geriatric component, and I'll shift gears now to present these results, hopefully. There we go. Jeff Williamson and I presented these results at the American Geriatric Society meeting last May, and we were fortunate enough to get this published in JAMA. So what I'll move to now is describing the outcomes in the Sprint Senior component, meaning individuals over the age of 75. So by way of background, why was this specific question? So most of you are familiar with this, but in this age group, the optimal systolic blood pressure target was especially controversial, and particularly in the oldest, most frail patient population. In fact, epidemiological evidence suggested there's an inverse relationship between systolic blood pressure and mortality. So the higher your systolic blood pressure, the longer you live. There's an abundance of epidemiologic data to suggest that. Okay. In addition, as geriatricians, there's a lot of concern about falls and fall-related injury due to antihypertensive therapy, and would we be putting old, frail people at risk of these adverse events from a lower blood pressure target? And finally, the cognitive and quality of life outcomes were not known. And again, would we be doing harm to bring older individuals to that more intensive goal? So fortunately, Jeff Williamson and others were involved in the design of Sprint at the outset, and fortunately, there was ARRA funding as a supplement to the Sprint trial that specifically enhanced the ability of the trial to enrich the enrollment for people over the age of 75. It's important to describe this population, and these were ambulatory community-dwelling older adults, so they were not nursing home residents or assisted living facility residents at the time of enrollment, and there was no prevalent dementia at baseline. So non-demented, ambulatory, older individuals. In addition to that, Sprint had other exclusions, and that's shown on this slide. So first, stroke. So past history of stroke was an exclusion, and this was because the SPS-3 trial was just about to finish up, so that was an exclusion. Diabetes. I understand there's some minor interest in diabetes among some of your faculty here. I don't understand why that is, but I guess there's a lot of diabetes in older people. Is that true? So diabetes was an exclusion. And in South Texas, yeah. So diabetes was an exclusion, and it's not because of its importance or prevalence in older people, but because of the ACCORD trial. Congestive heart failure because of symptoms, or either by symptoms or ejection fraction of under 35%, so reduced output congestive heart failure. And this is because the treatment regimen for Sprint would not have paralleled what cardiologists would be happy with for heart failure. CKD with a GFR below 20. And importantly, and I'm going to really harp on measurement, so standing blood pressure below 110 was an exclusion. So point one, not many people routinely measure standing blood pressure in practice, so that needs to be done. Point number two is this excluded 10% of the population over the age of 75. So this is not a trivial exclusion, right? So this, and in terms of applying the Sprint results to your patients, you need to exclude orthostatic hypotension or this low standing blood pressure if you're going to apply that. Yes, sir.
And the blood pressure was measured how? By somebody actually listening.
So this
when you go and get the automatics done, and then you have somebody turn right around and measure it with an actual cuff and a stethoscope, those readings often turned out to be wildly different.
Yeah. So these readings were done with an automated cuff, and I think that's the next slide. So let me move on to that. Yes. So, I'm using the reason I use my own laptop is so I can see what the next slide is. So I'm so far so good. So the next, to your point, the next important point about Sprint is the measurement protocol. And this is not routine practice for measuring blood pressure. Okay? It should be, and this is going to become the standard of care. And we can talk more about that. But, oh, it's good. So I'm preaching, so you're drinking the Kool-Aid for automated measurement? I am too, and this is why. So I won't read through this whole thing, but this is the SPRINT protocol. So as I think is being pointed out, the standard way we measure blood pressure, or medical assistants measure blood pressure, even if attention is paid to appropriate cuff size and a bare arm and sitting, etc., these other things are not routinely done, namely resting for 5 minutes in a quiet area, and then observer-independent measurements measured serially 1 minute apart. This is going to become the standard of care. And the delta that exists between this protocol and the usual office readings is somewhere between 6 and 10 millimeters of mercury. Would you agree with that? At least.
Is it biased? Is it biased in one direction or another, the delta?
It's lower. These measurements are routinely lower, but on average 6 to 8. In my practice, now that I'm doing this routinely, it's ranged up to 30 millimeters of mercury difference. So it's a huge difference. So so we'll come back to this, but the measurement, it's important to know how measurements were done, and if you're going to use this target, you need to make sure that you're targeting blood pressure measured the way that it was measured in the trial. Okay, geriatric outcome measures. So this is, as a geriatrician, one of our major limitations has been we haven't had evidence-based randomized controlled trial data in our patient population to be able to apply to our patients. We can celebrate that we have geriatric outcome measures from SPRINT to address a lot of these questions. Now, it's not perfect, but it's surely a lot better than it was in the past. So, for example, everyone over the age of 75 had gait speed measured at baseline and annually. I'm going to talk next about our approach to assessing frailty. Then, in addition, there's a component in the major description of SPRINT. It talked about tests or the outcomes on memory and thinking. So specifically, there's a cognitive component to SPRINT with a neurocognitive battery that was done at baseline, and then as triggered by an abnormal MOCA or abnormal screening test, went on to a full neuropsychometric battery. And a subset received brain imaging at baseline and every 2 years. And I'll come back to those outcomes in a minute. That's known as the SPRINT Mind trial. Then, importantly, given the concerns that existed about going to this low blood pressure in the older patient population, were adverse events and their data on PHQ-9 and health-related quality of life, falls and injurious falls, orthostatic hypotension, and although these data I've not seen yet, data on hospitalizations and nursing home placement are also being collected. Okay, so geriatric relevant outcomes, thankfully. So, frailty. And I know there's interest in frailty here within your program as well. For this large randomized controlled trial, we elected to use the deficit accumulation approach that's been developed and promulgated mostly by Ken Rockwood. And the concept here, if you're not familiar with this, is that it assesses a large number of aging-related deficits. The minimum is 30. And it's a simple enough approach that it almost doesn't seem like it can be valid, but it is, I will submit. And it's simple enough that even a clinical geriatrician can understand and measure and do. And it, more importantly, again, I'll hazard, I won't sell myself as a physiologist in the presence of the aging physiologist, but it fits with this complexity theory of aging. And as we age, complex systems break down. And they don't break down all at once, they break down in a cumulative fashion. And if you accumulate enough deficits, at a certain point, you can no longer function. So it turns out that certain point is 66% or 2/3. So a frailty index above 0.66 is not seen in living organisms, whether it's human or animals. I don't know in the marmosets, Adam, if frailty index has been developed. It's been developed in mouse models of aging. I don't know, and actually we should chat about that, actually. But you just don't see frailty indices above 0.66. It's not compatible with life. So it's basically the total number of deficits that you're measuring in your cohort as the denominator, and the numerator are the number of those systems that are abnormal. That's the frailty index. It ranges from 0 to 1, but as I said, you don't really see values above 0.7. So thankfully, and this is the value of going around and interacting with each other. So Ken Rockwood came to Salt Lake City for our Center on Aging retreat and gave a lovely presentation on frailty, and clued me in that he had just reported frailty outcomes from the HYVET study, the hypertension in the very elderly trial, and demonstrated that the same benefit in HYVET extended to the most frail of that cohort, and got me immediately to think, gee, we really should do this for sprint because it'd be important to look at these same outcomes as a function of frailty. So with that, just a brief review of the frailty index with age, and to show you how this looked for the sprint cohort. These are two population studies. I don't know if you've done this for SALSA, actually, Sarah. You should look at this. So from the National Long-Term Care Survey and the Health, Aging, and Retirement in Europe study, this shows the distribution of the frailty index with age. So for women in purple and the men in this kind of orange color, and the two different studies are shown here. So you see the gradual increase with frailty index with age, which would be expected. There's a consistent finding that frailty index is higher in women than men. So back to your gender question. And I'll get back to the trial, the demographics in a second. But this is a little intriguing to me because we know that longevity is higher in women, right? Women live longer, but their frailty index is higher. So there is a little, we can come back to that.
Is this BMI adjusted for men and women?
BMI is, I don't recall in this frailty index if BMI was included. It probably was, and so it would have been the normal range for that gender. So it would have adjusted in that respect. But good question. So then we overlay the sprint results. So now the solid lines for men and women are the sprint cohort. And I'll focus first, since I'm mainly talking about the sprint senior results today, is 75 and older. And the frailty indices in this age range are within the range of these other population-based studies. It may be a little less frail at the tail end here at the 85 and older group, but at least within the range of these other ambulatory populations. Now, of interest, frailty index at the younger age in sprint is higher than the average population. Any thoughts on, does that make sense? Any thoughts on why that would be?
That population was selected.
So you're on track, Jim. So it's, to get into sprint, if you were under the age of 75, you had to be at high cardiovascular risk. So you needed a Framingham risk score, I can't remember if it was 10 or 15%. If you were 75 and older, that was your Framingham risk score. You were already high risk. But to enter sprint at age 50, you had to be at higher cardiovascular risk. So that explains, or at least we suspect that explains why their frailty indices are higher at the younger ages. So with that, we went on to validate this index first, and this was published in Journal of Gerontology last year. And this was before the results were unblinded. So this was all the data at 2 years for all sprint participants for self-reported falls, injurious falls, and hospitalizations. And the most frail group is at the top here in green, the less fit, and then the fit group in purple. And for each of these outcomes, as expected, the most frail group had a higher rate of these outcomes occurring over the 2 years of the trial. So it seemed to be valid in that respect. So I'll come back to the frailty index then and the results in a minute, but I wanted to give you that background so that we can discuss and interpret how frailty impacted the results. So this is the baseline characteristics, the demographics of the participants 75 and older. So there were just over 2,600 participants, 75 and older, so almost a third of the sprint total population was over the age of 75. Again, we can celebrate that fact. So instead of 2% of the trial population being this age, to have that number was an incredible feat. To the gender question, so unlike what you expect for an average population of age 80. By the way, this is 2 years below the average age of the HIVET trial, if we want to come back to talk about the HIVET trial. So this is almost as old as the HIVET trial. But only 40% of this population were women. And the reason is, as I alluded to earlier, so your VA was a site, so one of the clinical networks was the VA. And clinics across the country from the VA, so the, in a sense, the contamination or the over-sampling of men from the VA clinics is largely responsible for that gender imbalance. Okay? Yes?
So was the population, I mean, there's probably not going to be very many of them in there, but were there people in there included, did anybody check for like type 2A, familial hyperlipidemias, things like that? Did people check for ApoE4 or 3, any of those kinds of things?
So I'm not aware that those detailed lipid analyses, and certainly to my knowledge, the genetic predispositions or ApoE4 status, I don't believe was done. And actually, do I have, to your question, so the total cholesterol values are here. I guess I don't have on this slide the proportion of the population who were on statins, but it was certainly over half. I don't remember the exact percentage. Total cholesterol is of 180, roughly. So back to the gender, so 40% women, reasonably ethnically diverse population, maybe not for South Texas with only 6%, 7% Hispanic, but 17% Black and a mix of others here. So on average, on entry, people were on 2 antihypertensive medications, and the baseline systolic blood pressure was just under 142. Okay? So that's the population. To speak to the geriatric characteristics on the next slide. So this was not a pristine, super fit marathon running group of older people. So gait speed first. So nearly 30% of the population had a gait speed less than 0.8 meters per second, otherwise known as impaired. Frailty index, so we used a cut point of 0.21 as, frail was threshold of frailty index in excess of 0.21. And nearly a third of the population had a frailty index above 0.21. Okay? And then from the cognitive perspective, just a second, Jim, from the cognitive perspective, the average MoCA score, and I mentioned this earlier to someone, so the average MoCA score is 22. So although dementia was excluded, these are not normal cognitive people. There are a lot of people here with, if half the people at a MoCA less than 22, there are a lot of people here with mild cognitive impairment. And I'll get back to the health-related quality of life scores in a minute. But Jim, may I?
Since gait is seems to be such an important variable, I just wondered if you could tell us a little bit more what 0.8 meters, or show us what 0.8 meters per second is.
I'm not sure I can walk that slow. So this is a 4-meter walk. Are you asking about the methodology, or so the methodology? So it's a 4-meter walk, usual gait speed. I believe the protocol for sprint had 2 trials. I can't remember, to be honest, I can't remember if it was the average or the best gait speed of those 2 trials. People were allowed to use an assisted device if they typically used one. And there's some variation. Sometimes we use 1 meter per second. That's easy because, again, as a geriatrician, I can only do simple math. It's 4 meters, and if their time is over 4 seconds, it's slower than 1 meter per second, right? So sometimes I just use 1 in my head as kind of the cut point, but most epidemiological studies, I don't know if Sarah or others want to comment on what you use in your epidemiological studies, but 0.8 is kind of commonly used as that threshold of impaired gait speed. And now I won't be able to translate this on little sleep and not enough coffee, but the other way to measure this, and there have been reports about this, how long it takes you to cross the street while the light is still green, right? And if below 0.8, you can't cross the street in the period of time that the walk light is on, right? Does that make sense? To use 0.8, is that a reasonable threshold for your studies too? Okay, so we have these geriatric outcomes to now interpret the results from SPRINT in this older population. So first, did we meet the target? How well did we do, as you know, your site here and 120 clinics around the country, and getting people to this very aggressive goal of 120? So they started at 142, so this is the standard group, and they're going to be consistently now shown in blue, and the intensive group will be shown in red. So the first point is this happened, so the clinics were able to get blood pressures down to the 120 target, or at least in that neighborhood, within the first 6 months. So we often, we get this response from our clinician colleagues, well, we can't get older people's blood pressure down that low. Well, the trial managed to do it, and whether it's salt restriction or chlorthalidone or the other things that were part of the SPRINT protocol, it wasn't that difficult, in a sense, to get to that target and sustain it over the course of the trial. So that's point one. Point two, the delta of 11.4 was what was targeted in the trial. And I was on the intervention committee, and every call, what's the delta? What's the delta? We got to drive the delta. And that also meant keeping the standard group at 140, and you can see there was a drift down. Right? So even the standard group dropped down a bit from baseline. This delta is about 3 millimeters less than what the overall trial resulted in of 14. So the delta was a little less in the geriatric population. Next point is the number of medications it took to achieve this delta. So on average, it took one more medication. So they started at 2, and at the end was 2.9. So to get that additional 11 millimeter decrease in systolic blood pressure required the addition, on average, of one more antihypertensive medication. Okay? So,
Question?
Yes?
So how much clinical variability was there for the people that are running it, participating in the study with a given patient in terms of the choice of drugs to achieve that target?
No.
Because sometimes one drug works and the next person it doesn't, and you switch to a different drug and you achieve the results.
So this was not a drug intervention trial, right? This wasn't the addition of X drug or Y drug. So there was a SPRINT formulary. Actually, one point I should make in this context, the drugs were provided free. So in terms of, again, access to medications, so in terms of how we should be doing better in implementing better blood pressure control in general, giving free drugs certainly was a big part of it in terms of adherence. But there was a SPRINT protocol. The preferred thiazide diuretic was chlorthalidone. And if people were on hydrochlorothiazide, the majority of people converted over to chlorthalidone. There will be a study coming out. My suspicion, the group's suspicion is that this drop here in the standard group was probably that switch to chlorthalidone. That's conjecture, but there is a sub-study that's going to address that question specifically. But to your point then, beyond that, people had free rein within that formula to choose what their options were to get to that target level. The most common combination of the three drugs was chlorthalidone, and then either an ACE or an ARB, and calcium blocker, most commonly amlodipine. So it's that triad.
So
does that address the question?
Most of these people were not on beta blockers, for example.
The minority were actually somewhere between 20 and 30%. There's a table in the supplemental information in the New England Journal paper that has that information. If I recall, it's about 20 or 30% were on beta blockers. Okay. So results. So we got the blood pressure separation. I showed you the results for the whole trial. What about in this geriatric population? So similar presentation. Again, the standard group in blue and the intensive group in red. And these are cumulative hazard ratios for the 75 and older participants for the primary composite outcome. And again, similar to the main trial, very early separation after 1 year. And consistent separation here. Hazard ratio of 0.66, so even greater reduction, so 34% reduction. in the primary outcome. A much lower number needed to treat of 27. And again, we're dealing with older people at higher risk. The number needed to treat is going to be fewer. For all-cause mortality, similar story. Hazard ratio of 0.67, number needed to treat of 41. Again, lower than the main trial overall. So that was reassuring, and this actually was in the main paper in the New England Journal, not this figure, but since this was a pre-specified subgroup of SPRINT, these data were in the main paper. But we wanted to separate it now. What about by frailty? So do these results also extend to the most frail population? So this is now broken down for the fit, the less fit, and the frail subgroups. Remember, this was almost a third of the population. Same spread, or same presentation. A lot of variability here. There weren't that many people in the fit group overall, so about 500 at the start. So a lot of spread here, but across the board, the hazard ratios are all in favor of intensive treatment, and especially, and in particular, in the most frail group, very comparable hazard ratios to the entire population. So that was reassuring. If you don't endorse this assessment of frailty and the deficit accumulation, we wanted to look at gait speed independently because people, as Jim pointed out, this is a very powerful data. Some people are encouraging this as a vital sign for geriatrics. So gait speed of 0.8 or greater, and so impaired or normal. And again, similar pattern. So even, in the impaired group here, the same benefit, the similar hazard ratios, the same benefit was observed even in the most frail, the people with impaired gait speed benefited equally from intensive therapy. I should point out, let me just go back real quick. I'm looking at the time, I want to make sure we get through everything. So I should point out the other kind of internal validation. There were, as you'll notice, as you go to increasing frailty, their hazard ratios are higher. There are more events. And you'd expect that the frail group would have more events. And similarly, for gait speed, the impaired gait speed had more events. So there's some internal validity there as well.
Mark, it's still a question.
Yeah.
I assume that people that had some event was taken out from this.
Yes. So if you're dead, you don't contribute to gait speed in year 3. So and exactly this is, and Nick and I haven't even had a chance to talk yet today, so he did not plant this question. But I'll pause here. So these results were not the frailty results at that point, but when the initial results were announced, actually my geriatrician colleagues from Michigan, who will not be named, he's now the head of the Pepper Center there, you may know him, I got an email. This is impossible, this can't be true, the older people must not have continued the intervention, they either died or they fell and they had an adverse event and they didn't contribute to this outcome. So what about the people that either had adverse events or dropped out and were lost to follow-up? So great segue. So adverse events so to your point, Nick. So withdrawn consent and loss to follow-up. So again, intensive in red and standard in blue. So overall, the rate of dropout was quite low. So 1.5, 1.6%. And if anything, it was a little bit higher in the standard group. And then when you break it down by either frailty status or gait speed, again, the more frail you were, or if you had impaired gait speed, you were more likely to drop out or be lost to follow-up. But there was no differentiation by treatment arm. So the intensive group did not have those loss to follow-up events any more frequently than the standard arm. So that was not the explanation. Okay? But a very important question on this. We're glad we were able to show this. So beyond that, the other concern, of course, are adverse events. So serious adverse events by treatment arm in the geriatric population. Again, overall, no difference by treatment arm. More events, the more frail you were, but no separation by intensive versus standard treatment. And I'll move on a little bit so I can move on to the next section. But and then conditions of interest. And there were some differences here, and it's important to keep this in mind. These benefits come at a cost. Cost of an additional medication and some issues with that and monitoring. And the events of hypotension, syncope, electrolyte abnormalities, mainly hyponatremia, and acute kidney injury were more common in the intensive treatment arm. And this was true for the main trial as well. However, injurious falls did not occur more frequently in the intensive treatment arm. This was contrary to what everyone expected and feared. If anything, it was a little bit higher in the standard group. So it wasn't falls that were the main complication. The last point about sprint, and then I'll move on to arterial stiffness. So the other question we had, well, does this generalize to the patient I'm seeing in clinic? Maybe not in the spinal cord clinic, but when you're in your VA clinic, does this really mean anything for the patients you're seeing? And do we apply these results to this patient population? So it's not everyone, of course. We need to be careful to follow the exclusions. But that said, so Adam Bress at Utah is a pharmacoepidemiologist, and he had a paper published in JACC the same day as the main trial paper was published. And he had this, so you know, if you get in the good graces of your hospital, their media group really does wonderful things. So he had them create this diagram for the whole sprint trial, and then I had him modify it. This is now specific to adults 75 and older. Okay. So the outer circle is that, so there are 220 million people in the United States, 17 million 75 and older. Of that population, 9.1 million have elevated blood pressure or are at risk for heart disease, right? So they would meet the sprint criteria. And then the drop from 9.1 to 5.8 are the exclusions, so diabetes, stroke, et cetera. So it's not everyone, but there are 5 million adults in this country over the age of 75 for whom the sprint results could potentially be applied. So from a public health perspective, you know, if instead of, I was talking about hypertension, if this was cancer, and I told you I had a cancer intervention that would reduce that primary outcome by 30% and reduce total mortality at 3 years by 30%, this would be $1 billion industry. But instead of a cancer that might affect 30,000 people in this country, this is a disease that confers the highest impact on disability that affects 5.8 million people over the age of 75. So that's who's at risk and who we need to be thinking about as we try to now move to the next step to implement these findings. But that's another talk. So I am mindful of the time here, so let me conclude. If there are other questions, I can quickly take those, but then I want to shift to the next part. So the Sprint Senior cohort, based on the Frailty Index data, is representative of community-dwelling older adults with those exclusions in mind. The rates of hypotension, syncope, electrolyte abnormalities, kidney injury were higher in the intensive arm, but not the rates of injurious falls or orthostatic hypotension. However, our conclusion is that overall the benefits from intensive blood pressure lowering of a 33% reduction in cardiac outcome and a 32% reduction in total mortality exceeded the potential for harm even among the most frail participants. So, yes, Jim, and then...
You have to ask one question. The mortality. Since all-cause mortality was, these people benefited, what fraction of mortality was not cardiovascular related? Bottom line, is there any evidence that other causes of mortality are benefiting?
Good question. The cardiovascular mortality is embedded in one of the tables. I don't remember off the top of my head what proportion of the total mortality was cardiovascular.
I mean, do you have any sense that other causes of mortality
would be not? No, you wouldn't anticipate that, right? But this, I mean, it's consistent, however, with results from the HIVIT study, which was stopped because of the reduction in total mortality in the HIVIT trial, and that was stopped at 2 years. So I don't know over and above the cardiovascular benefit what else would be demonstrated.
It's obviously a very important question in terms of the potential that this would have to convince the FDA for looking at drugs that influence age-related mortality independent of cause.
Yeah. Okay.
A couple of quick questions. Back to my question. So you're going to do long-term follow-up on the mental status here? Because you said a lot of these patients...
So actually, let me skip this. And again, great question. So we're not done with Sprint. So the sprint mind outcomes, the neurocognitive outcomes, were planned to go on to year 5. That was the hypothesis, that there would be a reduction in incident dementia at year 5. We just finished year 4. I'm on the adjudication committee for Sprint Mind. We just finished adjudicating the year 4 results. So Nick and I were just chatting about this. So there's an extension to Sprint that has been submitted to NIA and received what we believe is a fundable score to extend the cognitive outcome data collection for an additional year. Council is meeting this week, I believe, if I remember the date correctly, so we should know relatively soon whether or not that has been funded. And if so, that will allow us to continue to collect cognitive outcome data for an additional year. And similarly, the brain MRI, the imaging results have not yet been analyzed. They're still being collected.
And the other issue here is you said about half of these people are on statins. And statins, the effects of statins are increasingly being recognized as inflammatory. And inflammatory states have everything in the world to do with all of these aging processes, including blood pressure.
So, as you know, statins, the other side of the coin is, statin, there's a lot of people who think statins have other benefits potentially on cognition, and it should be in the drinking water. So there's another side to that story, too. So.
But what I'm asking is, are you going to follow up and crack any of this data out based on who is taking statins?
Yeah, I suspect that will be done. That's a different part. The Sprint Mind is a different group of folks, but I've been trying to help get the data adjudicated, but that's
Mark,
been...
I think someone on the bar shop.
Oh.
Yeah, I have a question here, Mark. Nice talk. So obviously you have a patient's blood sample. Are there any biomarkers being analyzed associated with this change in lower mortality, and also any metabolic changes like blood glucose and other things?
So only at baseline, Roger. And I mentioned that's another good segue to the next part of the talk. Then I'll talk about the arterial stiffness outcomes and some of the biomarkers that we had at baseline, but there are no blood samples done longitudinally, so it's only baseline information. Okay? All right. We'll move on. So in addition to this clinical interest, then what I was asked to cover as well is some of the mechanisms that relate to geriatric hypertension, particularly vascular stiffness. So I'll move on to this discussion. And again, I didn't plan. It's Roger, correct? Roger's question about biomarkers and metabolic syndrome, but we were quite interested in the impact that these biomarkers might have at baseline as a predictor of arterial stiffness in this population. So by way of background, we know that with aging, there's a decrease in vascular compliance, or the flip side, an increase in arterial stiffness, and that clinically manifests as the type of hypertension that we see in older people, namely systolic hypertension and an increased pulse pressure. Okay. So we know, and this is where I'm delighted I was able to meet with a number of the Varshop investigators here today, and I'm really looking for insight from you about how other indicators of vascular aging could be factored into this. In general, we know that with aging, there's an increase in arterial intima and media. And in the matrix in particular, there's collagen deposition, an increase in fibronectin, an increase in protein cross-linking mediated through advanced glycosylated end products, and to the point earlier about statins and inflammation, also a lot of inflammatory changes that could affect arterial aging. The net result of all of these changes, though, is an increase in vascular stiffness with age. So there's some additional biomarkers of vascular aging, and again, feel free to add to this list, but in addition to the type 1 and type 2 collagen accumulation, there are studies suggesting that there's upregulation of Ang2, ACE, and Ang2 AT1 receptor. The pro-inflammatory secretory profile in vascular smooth muscle has been demonstrated for IL-1 and 6, MCP1, PI1, and MP2. So again, this inflammatory state. And finally, and I know there's an interest here, as there is with our vascular aging group in Salt Lake City, on oxidative stress and the role of reactive oxygen on decreasing nitric oxide bioavailability and endothelial dysfunction. So all of these potential biomarkers could contribute to vascular aging. So in clinical studies, the way that the way the field has moved to assess arterial stiffness has been most commonly been done using pulse wave velocity. It uses the principle of applanation tonometry, where the sensor is applied to an artery that is applanated over in this instance, over the radius. And if those of you who are old enough to me remember when we used this manual device in ophthalmology the Schiatt's tonometer to measure intraocular pressure.
The Stone Age.
The Stone Age, but physics still works, right? The principles of physics like gravity still apply, even now, for us. So it's a non-invasive technique, and again, it's a simple thing that even a geriatrician can learn how to do. You need to do a couple things. You need to measure distance between 2 points. So we're interested in the central aortic stiffness. So we use the femoral, has been a long day, the carotid and the femoral, and you measure distance. Okay? And then the device gets a pulse contour from that sensor at both sites. And there's a time delay. It takes longer for that pulse wave to propagate when the aortic valve opens. It takes longer to get to the femoral site than it does to the carotid. Okay, pretty simple. And speaking of physics, so velocity is distance divided by time. I can do that math. You don't even need a statistician to help with that. And again, a principle of physics is that stiffer arteries, stiffer pipes, stiffer anything will propagate pulse waves faster. So sound waves propagate faster. So it's a principle of physics. It's really beautiful, and it works. So this has been kind of the clinical standard for arterial stiffness. So this was so I'm going to shift gears. I wanted to give this background because I'm now going to try to convince you that arterial stiffness is an important risk factor as a segue to why we're interested in looking at this now in the sprint cohort. So and this will set up the stage for what we had predicted would be the case, that we would see greater arterial stiffness with evidence of advanced glycosylated end products. So the literature suggested that glycohemoglobin levels, even in the normal range, these are not diabetic individuals, but if you had a high glycohemoglobin, you had lower aortic distensibility. Okay? So that was intriguing. Way back when, so this was a study I did with a fellow at that time at Michigan. Just before I left, we know that diabetic individuals have higher arterial stiffness. This was a study we did. We measured insulin sensitivity indices using an intravenous glucose tolerance test. And these were in non-diabetic, normotensive and hypertensive individuals over the age of 65. And you can see that the hypertensive individuals here in the solid line and symbols had, other way around. Hypertensives here, normotensives here. So in both groups, the more insulin resistance, so the lower insulin sensitivity, the higher the pulse wave velocity. And as expected, the hypertensive group had higher pulse wave velocity than normotensives. But the point is, even in the non-diabetic population, the more insulin resistant you are, the more stiff your arteries. So with that, the additional epidemiological background is that, first of all, we knew that pulse wave velocity increases with age. These data are from the Baltimore longitudinal study on aging from Peter Wojtkiewicz back ages ago, and show the age-related increase for both men and women in pulse wave velocity. And importantly, it's becoming evident that arterial stiffness is a precursor to hypertension. So there have been a chicken and egg question. We know hypertensive people have stiffer arteries. Is that the explanation, or does arterial stiffness lead to the development of hypertension? And I'll show you two examples. These data come from the Framingham study. And this is the development of incident hypertension in people in Framingham who are normotensive at exam 7. And just focus on the black bars. This is carotid femoral pulse wave velocity. So their pulse wave velocity at exam 7 was measured, and if you were in the highest quintile of pulse wave velocity, even though you were normotensive, when you came back, I think, if I remember, the delta is 7 years between their follow-up exams. 7 years later, you had a 55% chance of developing hypertension relative to individuals in the lowest quintile where that was about a 10% chance. So stiffer arteries predict the development of hypertension. Similarly, in the BLSA cohort, similar findings. So it happens whether you're middle age or later age. You can see the expected age-related increase in systolic blood pressure. But again, if you're in the highest quintile, even if you're normotensive at the outset, 12 years later, you're clearly in the hypertensive range. If you started in the lowest quintile pulse wave velocity, there's still an age-related increase in blood pressure, but not as steep, and you remain normotensive. So it seems that this has something to do with a precursor to hypertension. And finally, as an independent risk factor for cardiovascular events, this is a meta-analysis that was published Circulation, JACC in 2010. And I won't take the time since I'm running late here to go through all the details, but you can see that on average for total cardiac events, cardiovascular mortality and all-cause mortality, was about a twofold greater risk or hazard ratio for these events in the group with higher pulse wave velocity. But the important point to make here is that this adjusts for peripheral blood pressure. So there's something about pulse wave velocity independent of hypertension that is conferring these risks. Okay, so that was the setup for the ancillary study that I have. And the major hypothesis is that measures of vascular stiffness in sprint would be predictive of the main sprint outcome independent of the achieved peripheral systolic blood pressure. So that's what we're trying to test. There are three specific aims. The first is that at the end of the study, that individuals randomized to intensive treatment would have a lower pulse wave velocity. And by the way, because the methodology allows you to also assess central aortic blood pressure, we also have that as an outcome. I won't be presenting that today, but that's another data point that we have. We can chat about that. So that's the first specific aim. The second is really the ultimate aim, is if pulse wave velocity achieved at year 3 or at the end of the trial will be an independent predictor of sprint outcomes, the primary outcome. And over time, as we look at renal outcomes, incident dementia, and cognitive decline, if this measure of pulse wave velocity and the change over time will predict these outcomes independent of the peripheral blood pressure change. And then finally, with respect to the biomarkers, and I'll comment on this briefly, are there baseline associations with some of these biomarkers of what we would have expected, namely related to insulin resistance, activation of the renin-angiotensin system, and because there are a lot of nephrologists in sprint, they insisted that we put in some of these chronic kidney disease markers, which I'll describe, and I don't know anything about. Are there any nephrologists here? I don't think that Swatha was able to make it, but so we can talk about that. Are you a nephrologist?
Oh, no, wait a minute.
Oh, okay. I didn't want to say anything nasty about nephrology if they're here. The other help we would love from all the bright people here at the Barshop Institute, this is really the root question. What can we do to prevent the age-related increase in blood pressure? And if my premise is correct, that it's largely due to arterial stiffness, the question boils down to what can we do to prevent arterial stiffness? And this is where we need your help. So we know there's some things that can be done, and this Ed Licata's published paper that I borrowed this from. So first of all, like most good geriatricians, lifestyle should be first and foremost. So exercise is, of course, the best anti-aging drug that we have. And there are data that suggest that pulse wave velocity can be attenuated with exercise training. So we know exercise worked. I met with it's Swatha, I can't remember her last name, the nephrologist here this afternoon. Banswati, thank you. She was very interested in salt restriction in the CKD population, and that may have an impact on arterial stiffness. There's some interest here, I understand, in dietary caloric restriction. Is that correct, Dr. Masro? Is that, so that or caloric restriction mimetics, and I should really update this now. I guess resveratrol is old. Is passe. Well, this is Ed Licata's slide, so I can blame him. But rapamycin, or are there other interventions that we should be thinking about and testing as an intervention to mitigate the increase in arterial stiffness. So there are some drugs that we can use. Certainly these drugs that treat hypertension, so ACE inhibitors and ARBs. Aldosterone antagonists, we have a trial that looked at spironolactone and did reduce pulse wave velocity more so than thiazide diuretics, so that may be an approach. Step back to the statin question, that should be looked at. So Jim, back to your days of reproductive endocrinology. So should we look at estrogen effects in arterial stiffness in postmenopausal women? Bring this up again. And then the more novel drugs, and you may know there has been a lot of attention to potential age breakers, so the advanced glycosyl product breakers. Altigerum was the hoped for intervention there, and there actually is a study that shows a reduction in pulse wave velocity with that inhibitor, but it did not see the light of day. And either elastase or MMP inhibitors are other drugs potentially that could be studied in this regard, but I'd really welcome your input or thoughts about other biomarkers and other interventions that really could address this question, because I want to live to be 100, and I'd rather not be on antihypertensive drugs, so I don't want to have stiff arteries. So with that, I want to acknowledge the support from NHLBI, from the GREC, from the Utah Coordinating Center led by Alfred Chung, and my study coordinator was Jeff Childs. The BU Vascular Lab, and I neglected to update this, but sadly, Joe Vita died during the study. I don't know if any of you interacted with Joe at Boston University, and Naomi Hamburg took his position to finish up the study, and then the coordinating center at Wake Forest led by Walter Ambrosius. These were our clinical sites. And with that, I'll end with the bristlecone pine, which is the symbol of optimal aging in Utah. So you can read the description. These pictures are taken. We were talking about national parks. Did you get to Cedar Breaks?
Yes, I did.
So this is the oldest bristlecone pine in Utah. This is at Cedar Breaks National Monument. It's relatively young. It's only 1,265 years old. The oldest bristlecone pine is believed to be almost 5,000 years old. So you can read why this is a great symbol for our Center on Aging. And with that, I'm glad we took questions along the way, and I think we still have time for more questions.
Yes, you do.
Thank you.
Superb, superb. So, questions?
Mark, I have a question here.
Yes.
Mark?
Yes.
Yeah. So you left out one critical factor, which is the BMI. So there's a controversy about the BMI in older people. There's a statistical analysis that people who are slightly overweight can live longer and a healthier life. In your case, did you correlate with BMI numbers? And the second question related is biomarker questions. GDF11 has been labeled as the rejuvenation factors. So I'm wondering whether you could analyze the GDF11 level in your patient sample. That's two questions.
So let me address the obesity question first, and you're referring to this, U-shaped relationship with at least mortality and body mass index, and we know that with aging that tends to shift to the right, so you're better off being a little bit higher on BMI at advanced age. So I just want to refresh my memory. So the average BMI was just under 28 kilograms per meter squared, so it's modestly overweight group at baseline. I don't believe that any analyses have been done yet to really separate out the impact of body mass index specifically. It's been adjusted for in the analyses, but beyond that, I don't think anyone's addressed that specifically. So the biomarker, again, tell me what...
The GDF11, that's still a controversial issue because they did a parasymbiotic mouse model where they hook up the young mice with the older one, and they try to make older mice behave younger, and they claim that the GDF11 is responsible for rejuvenating older mice.
So obviously that was not done as part of the study. The Sprint data, you may know, the New England Journal has made a huge announcement that the data from Sprint are now publicly available, at least from the main trial. So with that, there are opportunities to submit requests for ancillary studies to SPRINT. If that biomarker can be measured on frozen either plasma or serum, and there are frozen samples stored in the main chemistry lab in Minneapolis, and you had funding to do it, it would be possible to request that being done. But that would require submitting the ancillary study and getting that approved. Can it be done on either frozen or serum or plasma?
I think so, but we have never done it here.
I'm not familiar with
it can. The problem is it's part of the controversy surrounding that protein is whether the antibodies that have been used to detect it are truly specific or not.
Is it ELISA asking?
Those have been measured primarily by Western blot.
Oh, okay.
So
it's not a straightforward.
No, there's still a lot of controversy about that protein.
So, like everything, it could be done. It just takes time and money, and whether.
Yeah, I think once a good antibody and a good assay is developed.
Okay. Yeah, sir.
I was at your talk at AGS, and I remember yes, it was very good, but I remember there was a lot of controversy and people, this goes against what we're kind of taught as geriatricians. We're supposed to use less drugs, not more drugs. But when I look at your inclusion, exclusion, I see patients in a geriatrics clinic, and most of them have dementia, lots of them have diabetes. So, they may be right. The patients that a geriatric physician sees or geriatrician sees probably may not fit this criteria. So I'm thinking that the results of this potentially should be really provided to generalist primary care providers because they're seeing a little bit healthier than what we see in the geriatrics clinic.
And that's a
I don't know,
great point, Sarah. So, right, these are not nursing home patients. They're not the patients who are referred into our comprehensive assessment clinics who already have dementia or, again, have diabetes or the other exclusions. So maybe you're right. It's just that although this, as I tried to make the case, at least based on the frailty index, this is relatively generalizable to the ambulatory older population in the community.
Right.
But you're right, we don't see that population in our clinics. They're seeing primary care providers in general medicine or family medicine or seeing nurse practitioners, and they're not coming to us because they don't have the geriatric syndromes that we're expert in managing. So since you asked the question, I'll put in a plug for this paper, and since I passed this over, I'll have a minute to come back to this. So Jeff and I put this together, and it's available online early in JAGS. I'm not sure, I don't think it's been published yet, but it should be out relatively soon. But these were some of the questions that we got after that presentation, so we wanted to be proactive and try to address these. So why were the SPRINT results discordant from the epidemiological studies? So the response to that, and if I can take just a minute to expand on this, the points we make in the paper is that, first of all, measurement, right? You need to exclude orthostatic hypotension, and what we do in randomized clinical trials is not what we do in routine practice, and not the data that is evaluated or assessed in epidemiological studies. So it's not standard protocol, et cetera. So rather than beat each other up, the epidemiologists will criticize randomized controlled trials because they're not generalizable. The trialists will beat up the epidemiological folks because there's no way you can get around confounding and residual confounding, right? So rather than having this ongoing battle, why don't we apply the randomized controlled trial environment? Measurement protocol, exclude orthostatics, focus visits on managing blood pressure, give people their medications for free, have a standard protocol, right? The things that we do in randomized trials, why don't we do that in clinical practice? So that's the first point. Do they generalize? So to your point, yes. Again, it's not everyone. There are 9 million people in this population, maybe 6 million or so. we can apply this to, and you're right, it's probably that 3 million that we're taking care of in our clinics and are seen in other places. The adverse events, I think I covered that, again, the dropout rate was not higher in the intensive arm. And again, most importantly for the geriatricians in the room, avoiding injurious falls, or the fact that there were not higher rates of injurious falls was the most reassuring thing. And actually, I mentioned, so when Ray Young emailed me when the results came out, when I heard just a couple days before the press release that the trial was ending, and when I first got the news, my study coordinator called me, and before I called him back, my first thought that went through my head was, the older people in the trial were dropping out or had some adverse event or had falls, and the trial had to end early because of adverse events in this older population. And we will be blamed, the geriatricians will be blamed for enrolling all these frail older people into the trial, and it would have been a disaster. So that was my immediate thought. So the fact that that did not occur was extremely a surprise, frankly, and very reassuring. Cognitive and kidney outcomes, we need to stay tuned. We don't know yet. And then, how low should we go? So actually, I thought I was going to have to address this, and since Miranda grabbed me early this morning, I didn't have time to read the papers, but so I just got it literally this morning when I checked my email. The Annals of Internal Medicine has guidelines from, I can't remember which groups now.
I don't know. Kind of meta-analysis.
There was a meta-analysis, and then they have some guidelines from whichever the groups were, and Sarah can pull it up. But they're basically recommending sticking with the JNC 8 recommendations, which is a public health hazard of 150.
150.
So they're ignoring, not only ignoring sprint, they're ignoring all the other evidence bases that we have. The JNC 8, and that's a whole other talk and story. But so stay tuned. The American Heart Association guidelines should be coming out very soon. And I'm not on the guideline committee. I haven't seen them. But the chair of the guideline committee is Paul Welton, who is the principal investigator for Sprint. And I would be shocked if there isn't some incorporation of these findings in the AHA guidelines. So this will continue to be controversial. The one I read the take home, so of course I just skimmed to the conclusion of the abstract from their paper, was that you should, quote, consider a lower target in those at highest cardiovascular risk. And that makes sense. And actually this is another, digressing a little bit, but nested within trials, there are people that benefit and there are people that don't. Who is it that's most likely to benefit? It's the people that are at greatest risk. So we do need to think about applying risk-applied or risk-stratified therapy and use this benefit-based approach to applying results of any clinical guideline, right? So we do need to do that carefully. So my counter to that meta-analysis is that, well, yes, exactly. It's people over age 75 are at greatest cardiovascular risk, and we do need to carefully consider the risks and benefits like we do in everything in clinical medicine. It's a patient-centric discussion. It comes at a cost. It's an additional medication. You have to come and see the doctor more regularly. Your sodium levels may drop. You may have this or that. But the goal, if your goal is to decrease your risk for heart attack, stroke, and death, we can get to that goal. It comes at that cost. If you don't want to pay that price, then we won't. Once we get the cognitive outcomes, and this is what we're all holding our breath for, if there is a cognitive benefit in the intensive arm, I hope that we'll have much better endorsement of this recommendation to go to lower blood pressure, not only amongst our colleagues, but our patients, right? Patients, my patients have, heart attack, stroke, so what? But dementia, if we can demonstrate that there's a signal for decreasing the incident rate of dementia, that I think will get people's attention. I'd lower my blood pressure to do that.
The effect on walking speed, that's pretty interesting. I mean, it's
well, that was just baseline. That wasn't longitudinal. That was just the results stratified by gait speed. As I mentioned in response to the question, we are going to be presenting data on longitudinal frailty over time. But what I showed today was just the baseline. stratification.
Oh, but I thought there was an improvement in lower risk of walking speed of less than 0.8.
Yeah, so the intensive group had a benefit.
Right.
Even,
right.
yes.
I mean, that's
even in the
fascinating.
Yes.
That's fascinating.
So
I'm
again,
sorry.
this is somewhat counterintuitive to what we're taught in geriatrics.
Yeah, right. I mean, that's...
So, and actually, I've had a lot of discussions with Ken Rockwood about this. And I'd like your thoughts, sir, actually. So, you know, as geriatricians, we appropriately tailor therapy appropriate to patients' goals in a patient-centric manner. And for the oldest, most frail group, we need to have discussions about their goals of care and what's important to them. Yeah, but I think on the flip side of that, we've potentially doing a disservice in that frail group if we're not offering potentially therapeutic benefits to them. So it's not just, well, yeah, we put in a palliative care consult and that's it. If, you know, we do have beneficial treatments, and the time to benefit, I didn't talk about in this, but the time to actually I talked about it in the paper. I take that back. It's in this paper. Time to benefit. Remember, this was 3.2 years. HIVET was less than 2 years. So if you're 85 and frail, I mean, maybe you don't want to live another 2 years, but you probably don't want to develop heart failure. And if you're already frail and you develop heart failure on top of that, you're not going to have a very good quality of life for that next 2 years. And I didn't show the breakdown, but of the primary cardiovascular outcomes, and this was true in HIVET as well as SPRINT, the major benefit is in incident heart failure. So if you're already 85 and frail and have impaired gait speed, and then you develop heart failure, that's not good. If you can prevent that old, frail person from the disability incumbent with new heart failure, I think that's important, right? And we do a disservice to our patients if we're not considering that.
I think part of the problem is people currently are not measuring frailty in the clinic, so they're defining frailty by comorbidity. Mm-hmm. And so we know based on your exclusion, people with those comorbidities this doesn't apply. But they don't know who don't have those comorbidities are frail because it's not being measured. Right. So maybe your trial will put the frailty measurement in the clinic.
Your work, I think all of our collective work with the attention on frailty hopefully is going to translate to that.
Yeah, that's great.
Yeah. Yes, sir.
So, when I looked at the title of your talk and you started the last part of your talk.
Yeah, I'm sorry I went in the back in reverse order. That was a...
Right. You got to that part at the end of your talk there. The question that popped into my head, and the reason I had already asked the question about statins and inflammatory, is the whole process of thickening of the muscle, cross-linking, all that stuff. What does that have to do? Is there some way you could look at the sympathetic component to that, the neurologic component to that, particularly since we have now established a direct relationship between neurons and the immune system. Mm-hmm. You know, I mean, they directly control and downregulate immune response through two cells, T cells and macrophages. So, you know, what is the hypertrophy here and the stiffness have to do with sympathetic tone
and the inflammatory
response that leads to all kinds of other aging processes in the enema.
Right.
Is there any way you can look at that here while you're studying this process? Because it seems to me like that's got to be...
Well, as you're pointing out, it's a very complex system. This is bringing back...
Look at catecholamines.
Yeah, so way back in my formative years when I first started my research career in geriatrics, my initial studies were focused on defining sympathetic nervous system activity changes and adrenergic receptor regulation in aging and in hypertension. So as you know, but just for those who may not, in contrast to almost every other physiologic system that's in your textbook that declines with age, the activity of the sympathetic nervous system increases, right? So we have roughly a doubling in plasma norepinephrine levels from young age or young adults to older adults, which is the equivalent of going from supine to upright posture. That's the stimulus to the sympathetic nervous system. So in the setting of enhanced sympathetic activity, does that contribute to arterial stiffness, to the inflammatory aspects and all? That's a great question. I haven't thought back on my early career as measuring norepinephrine levels and all of this for quite some time. Yeah.
What's the potential mechanism in terms of the blood flow or
The mechanism for...
potential mechanism? You talk about the lower blood pressure and lead this benefit, health benefit, but the lower blood pressure is not reduce the artery stiffness. That's right.
Well, as I showed you the very preliminary data, so it looks like the intensive group actually did have a reduction in pulse wave velocity at year 3. So I don't know yet. We're just getting into the analyses now to see whether this was one of the factors that led to the improvement in the primary outcome.
In terms of, I guess, it's only with the blood provided nutrition, oxygen, something like that.
Yeah.
And how
So if it is arterial stiffness, and I didn't delve into this, but back to physics, so again, I think we might have been talking about this when I had a lot of conversations today. But it really is, it's not just that the pulse waves are propagated faster through the arterial system, it's the reflected waves that come back. So in diastole, not only is there a forward wave going out faster, it's coming back more quickly. So the reflected wave, during diastole, you're exposing the organs that are most sensitive to that vascular insult, and those organs are the brain and the kidney. And you can ask Dr. Masrow, but I think it's probably true that the most consistent age-related changes physiologically are cognitive and renal declines. I'm sure there are others, but so that may be one of the mechanisms, that it's actually that reflected wave that is doing the damage, and that's why it relates to arterial stiffness.
If that is fine, so we can, Dr. Supiano will take some additional questions in the front. We'll break up for now.
Okay. Thank you so much. Really appreciate the question.